Hello everyone, Assalamu alaikum. I am Fiza Gilani, Chair of the APPNA-MERIT HIV Committee. Welcome and happy Father's Day to all fathers attending this webinar today. This is the fifth webinar of the HIV Awareness, Prevention and Education Project in Pakistan, jointly designed and led by APPNA-MERIT HIV Committee, in partnership with the Common Management Unit, Government of Pakistan, and the Medical Microbiology and Infectious Diseases Society of Pakistan. I would like to introduce today's moderator, Dr. Yusuf Sheikh. Dr. Yusuf Sheikh is a graduate of Dow Medical University, Karachi, Pakistan. He completed his residency training from University of Illinois, Chicago, USA. He is currently working as assistant professor at University of Massachusetts Medical School, Worcester, USA. He is the current president of APPNA, which is a local chapter of APPNA for New England. So Dr. Yusuf Sheikh.
Thank you, Dr. Gilani. Thank you, appreciate it. Today's webinar, as Dr. Gilani mentioned, is the fifth in the series of webinars on HIV in Pakistan. And today's topic is extremely important because we will discuss today the tuberculosis and HIV, the co-management and treatment of those two disorders and diseases. And as everyone aware of that, tuberculosis is endemic in Pakistan. When I was a med school and medical physician in Pakistan, it was one of the top diagnoses we used to make. And once when you have a population which has tuberculosis, and on top of that, unfortunately, they get HIV, it becomes a bigger problem to manage for physicians even. And luckily, we have an excellent panelist, group of panelists today who can discuss how those two chronic diseases can be managed without any problem. So our first speaker, the main speaker, is Dr. Awewura Kwara. Dr. Kwara is an infectious disease specialist in training in public health and tropical medicine. He's a professor of medicine at University of Florida College of Medicine. And Dr. Kwara's research is focused on understanding the clinical pharmacology of antiretroviral and anti-tuberculosis therapy in patients with the TB and HIV co-infection. Dr. Kwara has many NIH, National Institute of Health, funded research grants in the USA and is a native country of Ghana. And Dr. Kwara today will be talking with us about the HIV and tuberculosis co-infections, clinical presentations, management of HIV/AIDS in adults and children. Followed by Dr. Kwara's presentation, we have two panelists, Dr. Naseem Akhtar and Dr. Shobha Lakshmi. So I will introduce them later on. So Dr. Kwara, it's all yours now.
Okay. Yeah, so thank you very much for the introduction as well as the invitation to give this talk. Everybody can hear me well?
Yes.
Okay, good. Yeah, so I'm going to focus on three areas. The clinical presentation of tuberculosis in patients with HIV infection. And then in the treatment, there are really two or three very important issues when to start antiretroviral therapy after we've started TB treatment. So that fortunately, there's now data and very good guidance, so it's no longer difficult. And then the next thing will be to talk about the antiretroviral regimen options. Depending on which country you are, you may have many options or very limited options, but we'll stick with the WHO guidance because those options are available globally. And then finally, I will discuss the presentation of immune reconstitution inflammatory syndrome in people with TB. Again, the mortality from that is not that high, so it shouldn't really be a reason why we should delay antiretroviral therapy anymore. So starting with the clinical presentation, I'll present some cases, but obviously it's not all presentations, and we are going to hear also about clinical presentation in Pakistan. So you'll hear more about the presentation, but I will share a few cases. And let's start with a These cases are all from Ghana, where I do some of my international work, and I've been with Dr. Gilani to Ghana a few times. Now, this is a 35-year-old woman who presents with 2 months history of productive cough, yellowish sputum, but she has no hemoptysis. Importantly, she has fever, night sweats, weight loss, poor appetite, and dyspnea on exertion. And most of the patients who present with pulmonary disease will have these symptoms. She's not married. She sells liquor. She has multiple sexual partners, drink alcohol daily, but she's never been tested for HIV before. So you could see her chest X-ray, which shows a dense upper lobe consolidation or opacification. And because she's got productive cough, she was able to provide sputum. And in Ghana and most parts of the world at the time, the diagnosis is really by AFB smear. So they stain this and look at the under microscope, and they see the acid fast bacilli. So she was positive. So she's clearly got pulmonary tuberculosis. So the next question really is, what test should you be doing next? And what treatment should you be starting immediately? And people can answer for themselves. But it's very, very important that anybody diagnosed with TB should get an HIV test. It's an indication for an HIV test, irrespective. And then which treatment you start first really is tuberculosis, because tuberculosis is contagious. That's what they are presenting with, and you should start therapy as soon as possible. We'll mention the treatment, but again, it will be tailored to what you have in your local region. The second case is a 35-year-old male. This patient already has a diagnosis of HIV. CD4 count is close to 300, but has not yet started therapy. And this was all sometime in 2013, 2014. So treatment was rationed. It wasn't just generally available for everybody. So to start therapy, you had to have a CD4 count less than 250. So the patient then presents with productive cough, fever, night sweats, which has been going on for 3 months. Also has right chest pain and weight loss and anorexia. The patient is tachypneic, tachycardic, and on exam actually have cervical lymphadenopathy. So this patient, if you look at the X-ray, you can see the air fluid level here, and definitely has pleural effusion. So definitely has pleural TB and TB lymphadenitis as well. So this is another case of extrapulmonary TB. Most patients who have pulmonary, but especially in HIV, extrapulmonary TB is very common, and you should be on the lookout for that. Typically, again, they will start 4-drug TB treatment, chest tube is placed, and then the question now is, when do you start antiretroviral therapy? And that's one of the focus of this talk. I will switch to pediatrics. So this, for children, the presentation may be very subtle. So this is a 18-month-old child who is presenting with failure to thrive. So the child is admitted to the malnutrition unit and just has not been doing very well. But then you go into the history, 2.5 months before, the mother actually was admitted to the same hospital with suspected pulmonary TB. The child is under the care of the family since the mother is in the hospital, and they really delayed her presentation. So you do the chest X-ray, you don't really see very much as in adults, but you see hilar lymphadenopathy, which in a child, you should definitely be thinking about TB as well. So you examine the child is lethargic, has oral thrush, this should be thrush. and that definitely should give you a suspicion of HIV as well. And as you can see, the child is definitely malnourished and severely malnourished, such that weight for age and height for age is below -4 standard deviation. So this is a severe malnutrition. The child is, just before I get to the treatment, this is the mother's history. So she was pregnant, but never really got a prevention of mother-to-child prevention care during her pregnancy. So her HIV was missed and was only diagnosed with HIV because of the child's presentation. As you can see, her CD4 count is very low already, just about 100. And that's her X-ray. She's smear positive. And she was started on anti-TB treatment. But then again, this was the time where antiretroviral therapy is delayed. So she actually died 6 weeks into TB treatment without starting antiretroviral therapy. So to reduce mortality, we'll talk about the importance of starting ART as soon as feasible. So the child was started on TB treatment, and 1 week after was also started on antiretroviral therapy, which is important. In this case, she was started on abacavir, lamivudine, and nevirapine. And this was really the first line for children at the time in Ghana. She continued to have persistent fever. So because of that, she was treated for malaria. So you can see that malaria treatment is added to the TB and HIV treatment. So there could be some drug-drug interactions. Also, she continued to have fever. They started antibiotics, ciprofloxacin, and then cefotaxime. The X-ray was repeated, and as you can see, the hilar lymphadenopathy is more prominent. So is this TB iris or not? Very difficult to tell, but it could as well be. But eventually the child did very well. As you can see, has recovered pretty well, but has lost the mother and is now an orphan and had to be discharged to an orphanage. For older children, they may present very similar to adults. As you can see, a child presenting with cough, weight loss, night sweats. And when you do the X-ray, sometimes you are looking for opacity in the upper lobe, but in HIV, sometimes you can have the opacity in the lower lobe. And typically, they don't respond with antibiotic treatment. And even if she cannot produce sputum in this case, the presumed diagnosis of TB has to be considered. HIV should be tested, and empiric therapy typically should be started. So just to ask a few questions after these cases. So these are just a few cases to illustrate, but certainly in people with HIV, they can present with abdominal TB, disseminated TB, actually have bacteremia, genitourinary TB, pericarditis, spine, and meningitis. And you have to be aware about meningitis because you have to differentiate it from cryptococcal meningitis because the presentation is similar and treatment could be different. But typically the questions we should ask is the TB treatment in HIV the same as somebody who is HIV negative? When should you start antiretroviral therapy after you start TB treatment? What regimen should be used? And how do you monitor for toxicities and manage them? When you go to pediatrics, the same question. Is the pediatric TB treatment the same? What are the dosages to be used? Again, when do you start ART? And what regimens to use? And the monitoring, as you can see, can be very similar. So the treatment, just to go into TB treatment briefly before we go in, and I'm just focusing on drug-susceptible TB. Somebody with MDR or resistant TB typically should be referred to a specialist center. But susceptible TB, the treatment is the same, exactly the same as HIV negative. You start with 4 drugs, rifampicin, isoniazid, parazinamide, and ethambutol for 2 months, and that's considered the induction phase. And then after that, you do 2 months of rifampicin, isoniazid, and in most parts of the world, fixed dose combination that has all the 4 drugs in one, or the continuation phase where you have the 2 drugs in one, is actually preferred because you just give the medication and adherence is much, much better. In pediatrics, it's the same, except pediatrics cannot take the adult combination. So this is the brand new dispersible pediatric combination. And as you can see, it has rifampicin, isoniazid, and parazinamide combined into the fixed dose combination. And so there's an extra ethambutol tablet that should be given together with that in the induction phase. And in the continuation phase, again, they have the fixed dose tablet. Typically, they have a weight band. So you weigh the child based on the weight band, you know how many of the tablets they should be taken. And it's very simple. If directly observed therapy can be done, it's preferred. It can be done by parents, guardians, people in the community, and that really ensures adherence. So just to go into the interaction between TB and HIV is very, very important, and typically is bidirectional. It doesn't matter which came first, whether it's the egg or the chicken, but the interaction is bidirectional, such that people with HIV, if they've been exposed to the TB bacteria, they have much, much higher risks, almost 20 times more likely to develop active TB than somebody who doesn't have HIV. And somebody who has TB and HIV, TB increases HIV viral replication and increases progression of HIV disease and also mortality. So the consequences really is deadly, and that's why it's very, very important that we should treat both conditions in the same patient, and clinicians should be very comfortable to treat them. At the minimum, HIV providers, infectious disease physicians should be able to manage the HIV part of it. As you can see, this is incidence of TB, and this is HIV prevalence. So this is in the African region, and as the prevalence of HIV increases in any community, the incidence of TB also increases. I know in Pakistan, their HIV prevalence is much lower, but again, it's a very, very high burden country. So if you add up all the patients who have co-infection, it really adds up. So as a result of HIV epidemic, you could see that the incidence, unusual incidence of TB is reported as number of cases per 100,000 population. Again, the incidence in Pakistan, India is low, but if you look at the population level, it's one of the 8 high burden countries in the world. So your burden of TB is very high. The only thing is that the prevalence of HIV is low, but still the cases are high. Because of the high prevalence of HIV in sub-Saharan Africa, nearly 75% of all cases of co-infection in the world live in this region. But the management is the same everywhere you are. Just to point out that TB is the #1 infectious disease killer in the world. So very, very important that most clinicians should be aware of it. And again, is the #1 killer of people with HIV infection. But sometimes people miss to test them for HIV. So they may miss to make the HIV diagnosis until sometimes it's very, very late. So any patient you suspect TB should get an HIV test as well. Now I'll go into the challenges of managing HIV and TB treatment. They get standard TB treatment, but it's the HIV part of it. The timing is important. Drug-drug interactions inform what regimen you can use. And immune restoration disease, fortunately, the incidence is not very high and mortality is pretty low. Now, it used to be high pill burden because we are treating two diseases together. That's no longer an issue because of the fixed dose combinations. A high pill burden is no longer an excuse. Overlapping drug-drug toxicities, again, is not a big issue, so you shouldn't really be worried about it. You could monitor people clinically. If you have LFTs available, you could use them in your program, but monitoring people just to see if the tolerate treatment is enough. Now let's go into the timing. When I started all this in the 90s, early 2000s, there was really, nobody knew when you should start antiretroviral therapy. So because of that, antiretroviral therapy was delayed until they finished TB treatment. And this is a study from Thailand published in 2006. And you can see that there were two groups. One group that got antiretroviral therapy during TB treatment, and the second group that did not. And they looked at survival up to 5 years out. And if you can see that by 5 years, all the ones who didn't receive ART were dead. So there's no point to wait to finish TB treatment before you start ART. If you start ART early, it really saves life. Now there've been randomized studies looking at when to start therapy, and I'll just show just two of them. This is a study out of South Africa. They looked at integrated versus you finish the TB treatment first and then you start HIV treatment. And again, they looked at survival. And as you can see, the integrated group did much, much better and were most likely to survive. Those who waited to finish TB treatment, again, survival was much, much lower. And the earlier you start the treatment, also the better. So the other study that is widely talked about is the Camela study out of Cambodia. And people interested in this can actually pull the studies. But again, they compared early within 2 weeks versus late within 8 weeks. And as you can see, again, early treatment is associated with better survival. So it's only a matter is when to start. And before just this year, it used to be a start within 8 weeks. So between 2 to 8 weeks of TB treatment, you should start ART. But just 2 months ago, WHO has revised their guidelines. So this is really brand new as of March 2021. And now they've harmonized the recommendation. So ART should be started as soon as possible within 2 weeks of starting TB treatment. So this is all comers. The only exception is when you suspect TB meningitis. You can delay a little bit. So pediatrics, adults, once you start the TB treatment within 2 weeks, you should be starting ART. And this is really brand new recommendation. If your country hasn't started implementing it, I'm sure you probably start implementing that this year, and it will make things easy. If you look at people with HIV alone, now they are starting HIV treatment as soon as a diagnosis is made. So they don't really, irrespective of CD4 count, everybody starts ART. And same thing for people with co-infection. Now, when you suspect TB meningitis, you should really also consider cryptococcal meningitis because the treatment is different. And in each case, you want to delay ART for 4 to 6 weeks so that you can reduce the incidence of immune restoration disease, TB iris. Because people with meningitis, when they have iris, there's inflammation within the brain, the cranium. You could see that edema alone could increase mortality. So that's why you should delay ART. But you should start after 4 weeks, definitely within 8 weeks of TB treatment. Again, hopefully we can have questions at the end. I'll just go into the ART options. And the reason why it's difficult is that you have to treat 2 infections, each with 3 to 4 different drugs. So we don't intentionally get together to throw in medications that don't interact well. It's just because rifampin in the TB treatment induces metabolizing enzymes for the ART. So rifampin typically is a co-receptor. It binds to what they call PXR. And what it does is that it increases the transcription of the enzymes. So more enzyme is induced. So CYP3A4, for example, for the protease inhibitors, CYP2B6 for efavirenz, UGT for integrase inhibitors, all those enzymes are induced. And therefore, if you give a medication that is broken down by those enzymes, those medications are quickly broken down. This is an example of a medication that when you give it alone without rifampin, look at the big area under the curve. And now when you give it with rifampin therapy, the medication is almost wiped out. So it's not going to be effective. There's another system that is important with the interaction. It's called P-glycoprotein, and it's on the enterocytes of the GI tract. And what it does is it pumps medications back into the GI tract and prevent absorption. So if this is a staining for P-glycoprotein, and after 9 days after you give rifampin, you can see how strongly induced P-glycoprotein is. So it actively pumps out protease inhibitors back into the GI system, and therefore the medication is not absorbed. So overall, protease inhibitors, very, very little will get into the system. And that's why often is contraindicated. So this is a very, very good article which you can pull up if you want. But some of the important classes of medication, Maraviroc is a CCR5 inhibitor. The levels are reduced by 63%, so you can't use it with rifampin. Bictegravir is an integrase inhibitor, you can't use it. Dolutegravir is really what is available globally. It's reduced by 54%. So what the guidelines recommend is to double the dose, and I'll go more into detail with that. If you have raltegravir in adults, you can double the dose or you can do standard dose. It's reduced by 40%. But in pediatrics, if you have it, you need to double the dose. Efavirenz, it used to be dose adjustment, but from all the studies, there's no substantial change with TB treatment. So no dose adjustment is needed. So you just use the standard dose, and most places will use efavirenz-based therapy. Etravirin, nevirapine, rilpivirine are not recommended, except if it's the only drug, nevirapine can sometimes be used. The protease inhibitors, most often, they are not used with rifampin therapy. I'm not going to talk about rifabutin, but if there's rifabutin available, you can actually definitely use that with protease inhibitors. So this, for example, is in the US, where we have all the options. So many classes of medication, so many options available, and even the combined fixed dose combinations. Look at the number of options available if you don't have TB co-infection. Now, if you have TB co-infection, almost everything is wiped out. Your options are basically reduced to just a few drugs. The NRTIs, they don't have significant interactions, so you can use those, and you can pair that with efavirenz, maybe nevirapine with dose adjustment, dolutegravir definitely with dose adjustment, And if you have the fixed dose combinations available, I don't know, we'll hear about what you have, but definitely the combined efavirenz, lamivudine, tenofovir can be used without any dose adjustment. So in adults, what is recommended? If dolutegravir is available, adults and adolescents is really the first line, the preferred. And you use it with 2 nucleosides, but the dolutegravir dose usually is 50 milligrams once a day, so it has to be twice a day. So, and I will show the fixed dose combination, how it's given with a supplemental dose. If you have a efavirenz-based therapy, you don't need any dose adjustment. Just give the standard just as you give to somebody without HIV. Now, sometimes people have kidney disease, they cannot take tenofovir, or there's a contraindication, you can replace that with AZT, and the treatment is the same. Or in some places, they can replace that with abacavir. So it's very simple, and based on national guidelines, you have what is preferred and the alternative, and very easy to do these days. So now this is where dolutegravir has been rolled out as universal regimen. It comes as a fixed dose combination, so you have 3 in 1. So in that case, if somebody has TB co-infection, they definitely take the 3 in 1. And then in addition to that, they take an extra 50 milligrams of dolutegravir. So some people will say, take the extra milligram in the morning and then take the fixed dose combination in the evening, or the vice versa. It doesn't matter how you do it, but very simple to implement for adults, adolescents, and now children weighing greater than 20 kilos can definitely take the dolutegravir-based therapy. Now, these are options when you don't have efavirenz or dolutegravir. Then you could use nevirapine, but there's no lead-in, or sacubitril. These are with ritonavir, but very, very high dosages of the ritonavir component. So hepatotoxicity is very, very common. So these are really, I'm sure they will be phased out very soon. Raltegravir in adults, some people will use it with no dose adjustment, others will double the dose. It really depends on what your national guideline says. In children, you can see that it's more complicated. You have to break it down: less than 3 years, older than 3 years, weighing more than 20 kilos, less than 20 kilos. So it's fairly complicated. And this is the WHO guidelines 2016. It will be revised this year, but to make it simple, if you have a child with TB HIV co-infection, they weigh greater than 20 kilos, you should just definitely use dolutegravir as you use in adults. If they are older than 3 years, but weigh less than 20 kilos, you should use efavirenz, and you use the same dose, the weight band dosing, without any dose adjustment, just like in HIV negative. It's those who are younger than 3 years old that we still have problems. Dolutegravir is being studied, but it's not yet in the recommendation. So if you have raltegravir, you can double the dose of that. If you have nevirapine, they don't have very good dose adjustments. So the only thing they advise is just use the standard dose as HIV negative, but don't do the 2-week lead-in, because usually you do nevirapine once a day for 2 weeks, and then you go to twice a day. So in somebody with HIV, you just go straight to twice a day. If you use lopinavir, ritonavir, you have to add more ritonavir dosages so that the milligram is the same. So if lopinavir comes to 200 milligrams, ritonavir should be 200 milligrams. And this is, but less than 3 years old, we really have very limited options. So finally, I'll just go into TB-RS. It's something that you should look out, but very, very manageable with steroids. So this is a case where, again, out of this article, 34 years old, low CD4 count, has TB HIV co-infection, has started TB treatment, And within 12 days, they are doing better. So they've started HIV treatment. And then 3 days after starting ART, they now have fever, anorexia, increasing cough, and you do a chest X-ray, and you can see that the chest X-ray is worse. Usually, you want to make sure that they don't have resistant TB. We already know that they are, based on gene aspect, they are rifampin susceptible. So it's reasonable to think that this is TB iris. They start prednisone 80 milligrams a day, and within 2 to 3 weeks, all the symptoms have resolved. And then you have to taper the prednisone down quickly or slowly, depending on how the patient responded. Again, it can be TB lymphadenitis. You start ART, they start to be more swollen, more red, more inflamed, or they start to scar. This is all TB iris. Often you just need to exclude resistant TB or other opportunistic infections, but you should definitely continue TB treatment, continue HIV treatment, and you can add steroids. Even before HIV came along, TB iris was recognized, even with TB treatment. This is somebody with TB, pre-treatment, they start TB treatment, it starts to get worse, and by day 28, they even have worse symptoms, but then when you do the culture at this point, they've already become culture negative. So it's all TB iris. You don't need to stop TB treatment, just continue. So just to summarize, it's a paradoxical worsening of TB symptoms. Or the other thing you should know is sometimes somebody has HIV, they don't have active TB. You start them on TB treatment and within 2 months, they show TB symptoms. That is also TB iris or max TB, and it should be recognized. You continue HIV treatment and you just, the appropriate one, and you just add on TB treatment. It's an immunopathologic response. It's not because they are not getting better. Mortality is rare except in TB meningitis, and you continue ART and just add steroid therapy. So just to summarize, TB HIV co-infected is associated with increased mortality. ART started early will save life, and it should be started as soon as possible. And the new guideline says within 2 weeks. ART regimen, depending on what is available in country, can just be adjusted. Efavirenz, no dose adjustment needed. Dolutegravir, double dose. And TB iris can easily be managed. Just be on the lookout for it and manage with steroids. So I will stop here and stop sharing. And I don't know at what point we will do discussions or questions.
Thank you, Dr. Kwara. And just a few housekeeping items, so we will, please type your questions in the Q&A section on the right bottom of your screen. And we will discuss the questions and answers at the end of the presentations. After all the presentations are done, then we will have time to go to each question. So I'm reading all the questions, but we will answer them at the end. So now we'll go to our panelists. So we have 2 panelists here right now, Dr. Naseem Akhtar and Dr. Shobha Lakshmi. Dr. Akhtar is the graduate of Army Medical College in 1999. She is currently the assistant professor and head of Department of Infectious Disease at Pakistan Institute of Medical Sciences, Islamabad, Pakistan, the PIMS Institute. She's also working as the Deputy National Coordinator for Tuberculosis at the Common Management Unit, the CME unit, Government of Pakistan. She's also in charge of the HIV Center, ID and Isolation Ward. She's also the focal person for the dengue, polio, malaria, HIV, AIDS, and COVID-19. She also co-chairs the District Infection Control Committee in Islamabad, Pakistan. Dr. Akhtar will discuss HIV-TB incidents and common presentation in Pakistan. Our next panelist will be Dr. Shobha Lakshmi. She's an assistant professor of infectious disease at Dow Medical College in Karachi, Pakistan. She's also an official bearer of Medical Microbiology and Infectious Disease Society of Pakistan, the MMIDSP. Her special interest in infections in immunocompromised and tropical medicine. And Dr. Lakshmi will talk about the treating TB and HIV co-infected patients, treatment options and medication availability in Pakistan. So that's very important for some of the people have been asking about what are the options in Pakistan. So Dr. Kaur, thank you once again, and we'll come back to you once we start the question and answer session. So doctor, it's all yours now. You can share your screen, Dr. Akhtar. Yeah.
Okay, can you see my screen?
Yes.
Yes, but do presenter mode.
Yeah, I'm trying to.
Time left from beginning, top left. Yeah. Yeah.
Okay, thank you very much. I will start my talk with the first case. Basically, I'm presenting two cases who presented to my clinic of infectious diseases, and the case presentation will be followed by the other part of the presentation, that is incidence of tuberculosis in Pakistan and the challenges which are faced by us. So my first case is a 26-year-old male patient from Islamabad who was businessman by profession. He was a known case of HIV and was recently diagnosed about a month ago, and he was already taking antiretroviral therapy that was tenofovir, lamivudine, and efavirenz based, and his initial CD4 count was 274. He presented to us with 1 month history of high-grade intermittent fever with rigors and chills, and he also had 1 week history of poor oral intake, drowsiness, irrelevant talk, and altered behavior. He was a married man. He did not have any offspring. Spouse tested negative for HIV, and there was no history of substance abuse, and he denied any extramarital relations. On examination, he was found to be mildly pale. His GCS was 13/15. There were no signs of meningeal irritation, and he was not having any focal neurological deficit. Rest of the systemic examination was unremarkable. So on the basis of his history and the background of HIV, we made a list of differential diagnoses for him. That patient might be suffering from, toxoplasmosis, nocardia, CNS tuberculosis, brain abscess, or might be having some meningoencephalitis. So patient was investigated, and on initial investigation, he was found to be anemic, and it was microcytic hyperchromic anemia. His liver function test, renal function tests, and electrolytes were normal. His hepatitis B and C screen was negative. Syphilis screen was also negative. His chest X-ray, ultrasound, abdomen was also negative or normal, and he tested negative for toxoplasmosis. This is the CT scan of this young man, and here you can see that there is a heterogeneous area in the right parietal region. This is a T1 flare image, and here, as the arrow indicates, you can see that there is altered signal area on the T1 weighted images, and this is probably indicating some sort of infection which is undergoing. This is T2 flare image, and here you can see that in the right parietal area there is a large altered signal area which is appearing, hyper intense. So diagnostic burr-hole craniotomy was performed, and tissue was sent for histopathology and the cultures. The specimen was also sent for gene expert for Mycobacterium tuberculosis and rifampicin sensitivity, and the tuberculosis was identified on expert testing, and there was no RIF resistance. Subsequently, we obtained bacterial fungal cultures which are negative, and later on, after a period of 1.5 months, we were able to have the culture report, and which showed pan-sensitive tuberculosis, which was sensitive to all first-line anti-TB drugs, including isoniazid, rifampicin, ethambutol, and pyrazinamide. So our definite diagnosis was tuberculous brain abscess, and we started treatment for this patient with anti-epileptics, steroids, and the first-line anti-TB drugs, that is isoniazid, rifampicin, pyrazinamide, and ethambutol based on his weight, and the pyridoxine was also added. So clinical course was complicated by postcraniotomy hypertension, and patient also later developed hypokalemia, hyponatremia, bed sores, hepatotoxicity, visual hallucinations. So we had to, modify anti-TB drugs multiple times in this case. Patient was already taking antiretroviral therapy, but since we were rolling out dolutegravir in country, so we switched the patient to dolutegravir-based regimen, which included dolutegravir, lamivudine, and tenofovir with an extra dose of dolutegravir, as the patient was already taking rifampicin-based regimen. So iron and folic acid supplementation was done, and his hypertension was controlled with amlodipine and valsartan. Vitamin D and calcium supplementation was also done. So this was the first case, and now the second case is a 32-year-old male patient who was laborer by profession. He was heroin addict, and he presented to us from a city of Ahmedabad. He presented to us with 3 months history of low-grade fever, severe generalized weakness, productive cough, oral thrush, and a significant weight loss of 20 kilograms. He was recently found to have HIV, and his CD4 count was very low. It was around 47. And he was referred from a TB treatment site, which is at Murree in Pakistan. So patient has history of long-term IV drug abuse along with heroin and church addiction. He was married, having 1 child, and his spouse also tested negative for HIV. On examination, this patient was very emaciated and lean. He was having oral thrush, his vital signs were normal, and there were few basal crepitations on chest auscultation. He was also found to be anemic with having leukopenia and lymphopenia. Liver function test, renal function test, and other investigations were normal, and his syphilis serology was positive, though he tested negative for hepatitis B and hepatitis C. His HRCT was performed based on his history of productive cough and weight loss, and there was a possibility of having tuberculosis in the background of HIV in this case. So the HRCT showed multiple tiny, poorly defined centrilobular nodules, and some of them giving tree and bud appearance and mild bilateral pleural effusion. Here you can see, this is the HRCT, and here you can see the pleural effusion, which is more prominent on the right side, and there are multiple areas of tiny nodules scattered in both the lung fields. And this is the closer view of the CT scan of this young man. His sputum studies are performed as he was able to produce sputum, and the sputum showed on smear 3+ AFP bacilli, and MTB expert testing was also performed, and it showed rifampicin resistant Mycobacterium tuberculosis. So this was a surprise for us, but because we most often see the cases of rifampicin sensitive cases in HIV, majority of them are sensitive, but sometimes we do come across RIF resistance TB cases, not only in pulmonary positive cases, or sometimes in extrapulmonary cases as well. So this patient has recently been seen in our clinic, so further testing is still awaited. So this was a case of multi-drug resistant tuberculosis. And again, at the same time, I would like to mention over here that since he already had pleural effusion as well, so pleural fluid was also sent for analysis, and it showed a white count of 742 with lymphocytic predominance. It was an exudative effusion with protein of 4 grams per deciliter and glucose of 79. Again, in this fluid, acid-fast bacilli were positive on smear, and they were 2+. So pleural fluid for gene expert testing was also sent, and it also showed rifampicin resistant tuberculosis. So you can see that in one patient we have found MTR resistance from 2 areas, that is from sputum as well as from the pleural fluid. So the patient was having a very poor functional status, and CD4 count was also very low. So we started him on all oral regimen, since in Pakistan we are now rolling out towards all oral treatment for multi-drug resistant treatment. And this is the treatment regimen which we put on. And once the patient was able to tolerate the anti-TB drugs, we also started him on the antiretroviral therapy, which is available in Pakistan in fixed dose combination, which includes DTG-based regimen, including lamivudine, dolutegravir, and tenofovir. He was also started on PCP and Candida prophylaxis at the same time. So basically, the aim of presenting these 2 cases for that sensitive as well as drug resistant cases are not a surprise in the background of HIV, especially when once the CD4 count is too low, these patients are very much prone to develop, either a CNS TB or disseminated TB as well. We do come across so many cases of HIV who present with miliary tuberculosis, and at the same time they also have CNS tuberculosis. So we have to carefully evaluate all those patients to rule out if CNS infection is there or not, because in case of CNS TB, we have to prolong the treatment regimen. So I would be quickly touching upon the HIV situation among TB patients. Globally, people living with HIV are 26 times more likely to develop TB disease than those who are HIV negative. And the incidence of HIV and TB cases was 2.4 per 100,000 population in Pakistan. And these are roughly about 5,100 incident cases recorded during 2019. So importantly, in the absence of appropriate care and prevention, a large proportion of people living with HIV, they die from undiagnosed TB. And in 2019, there were 1,900 HIV-associated TB deaths in Pakistan. I would like to mention over here that there are TB HIV sentinel sites who are at which both TB and HIV testing facility offered, and there are around about 40 areas or facilities where these facilities available all across the 4 provinces. This slide basically shows the trends of TB HIV testing during 2019 and 2020, and you can see from this slide that in Pakistan the testing of the TB cases which are tested for HIV is very low. It is roughly either 50% or below 50%, and the TB cases who were found to have HIV was also very, very low, and we need to focus more on it. And our TB program is more focusing now that all HIV positive cases should be tested for TB, and all TB cases should be tested for HIV. So we will be, disseminating this message all across the country, and we are working more on this policy that this practice should be uniformly, disseminated all over the country. And this is the only way forward to diagnose more HIV among TB patients and more TB in HIV patients, because this is correlated so much with each other. So again, this slide basically shows the trends of HIV positive TB mortality rate per 100,000 during the years of 2011 to 2020, and this is variable. And you can see that initially in 2011 it was 0.69, and then there were more ups and downs, and in 2020 it is roughly 0.9. But since the testing is not universally being done everywhere, so it's very difficult to comment on the actual mortality among the positive cases. So the challenges which we face are that HIV epidemic continues to fuel the tuberculosis epidemic, and nearly 50% of all TB patients did not know their HIV status globally as per 2012, and only a little over 50% of those with associated HIV infection received antiretroviral therapy. So limited TB HIV collaboration at all levels of healthcare system, poor screening of TB patient for HIV, even for most at-risk population, is a big challenge. And significant proportion of people living with HIV are not screened regularly for TB. And latent TB treatment in HIV is another big challenge on which in the coming years we are going to work more. So there are a few action points to decrease TB, HIV among TB patients and TB in HIV positive cases, and these are universally known as 4 I's. This include, intensified case finding, that is screening of 100% TB cases for HIV, testing HIV for active TB cases, establishment of cross referrals between TB and HIV/AIDS program, delivery sites, and HIV counseling and testing offered to all TB patients. Then isoniazid prophylactic treatment for PL-HIV after excluding active TB, and every HIV patient to be put on IPT as per WHO guidelines. Integrated case management, including ARV and DOTS therapy, and most important, the infection control measures in the healthcare settings. The way forward is basically we have to, provide universal testing of HIV and TB among these 2 high-risk areas, and INH prophylactic therapy for PL-HIV to be started as per guidelines, integrated case management for TB-HIV co-infection, antiretroviral therapy for HIV and DOTS for TB, effective infection control measures to be in place, chlorotrimazole preventive therapy for HIV-infected TB patients. National capacity building is another area, and operational research is it's always so important to work on these 2 areas. So here I would stop, and if there are any questions, I think at the end of the talks we are here.
Thank you, Dr. Akhtar. I will go to Dr. Lakshmi. Dr. Lakshmi, you want to turn on your screen and share your slides, please? Dr. Akhtar, you want to stop sharing your slide? Oh, yeah, you did it. Okay, good. Thank you. Dr. Lakshmi, you are muted. Can you unmute yourself, please?
Yeah. So good evening, everyone, and an excellent talk by Dr. Kwara and Dr. Naseem. And I think the majority of the points has been covered, and I would not take much time and would focus on few other things for focus on the clinical presentation in Pakistan, the drugs available in Pakistan, and the treatment therapeutic options related to HIV, ARV drugs available in Pakistan. So this is a usual scenario which we see in our clinical practice, that people, a middle-aged man, 45 years old, and presented with history of fever and weight loss for 2 years and shortness of breath for 1 month. On examination, he was a thin, lean man with significant wasting. He was tachypneic and maintaining saturation on 5 liters of oxygen. His chest X-ray showed bilateral infiltrates, and the patient had received treatment for pulmonary TB 20 years back. On evaluation, his TBC was 8.5, PLC was 2.5, platelets were 25. His AB smear and gene experts were negative. He was HIV reactive, and his CD4 count was around 12. This is a usual scenario we see in our population, that people present with us in a state when they have category 4 disease. They do not know about the HIV status. They may have been treated for TB in the past, which may be one of the manifestations of an HIV initially. But because the testing is not available, people are not aware, they present very, very less. And they present with opportunistic infections. So this is a scenario in Pakistan. So the objective of my talk would be that I will be touching epidemiology of TB and HIV co-infection a little bit, treatment options available as soon as it's preventive therapy, the therapy which is available in Pakistan, and integrated TB and HIV care, as Dr. Naseem has discussed. So we all know and had been discussed that TB caused 1 out of 3 deaths among people living with HIV globally. And TB is the most common opportunistic infection among people with HIV. HIV increases the risk of dying of TB by 3 times. And of course, as Pakistan is a high burden TB country, so the risk of acquiring TB and dying of TB is really, really very high. So in 2019, worldwide, deaths from TB and HIV infection were 208. TB deaths from TB were 1.2 million, and deaths from HIV alone were 690,000. But this may be underreported. I mean, this number is underreported and this number is underreported. As because the testing is not widely available, some of the patients, TB patients, may be having HIV, but they were not tested. Some of the patients who had HIV, who died because of TB, but they were not tested for TB. So integrated management, as discussed, and integrated testing, integrated care is needed as in our part of the world, as discussed by Dr. Naseem. So a little bit of pathogenesis and has been discussed by Dr. Kwara, so not go into detail as we are short of time. That HIV basically weakens the immune system, and the immune system, because it weakens the immune system, the TB, which may have acquired years back and has been walled up by the granuloma formation and macrophages, the walls break off, and the bacilli disseminates into the body, and they present with biliary TB, disseminated TB, TB lymphadenitis, TB bacteremia, and CNS TB. So risk of TB increases by 2 to 5 folds in early HIV infection and more than 20 folds in advanced HIV infection. And one of the reasons is known as is depletion of CD4 T cells. But ARV can also accelerate the immune response to Mycobacterium tuberculosis, resulting in immune resistance reconstitution syndrome, as discussed by Dr. Kwara. That this is a reaction to the tuberculosis bacilli, the dying tuberculosis bacilli, when the patient's immune response is mounted against the Mycobacterium tuberculosis antigens, and this results in worsening of the symptoms of TB. And it has also been seen that co-infection with Mycobacterium tuberculosis actually acts as a factor for HIV progression into the severe disease as a little earlier. So what actually happens is this diagram shows that when someone is HIV negative, acquires MTB, 90% of the cases they progress to the latent TB, and the risk of active TB is actually 5 to 10% in a lifetime. But if someone is HIV positive and has TB, is exposed to TB, the risk of active TB is really higher, or the risk of progression to latent TB to the active TB is also higher. And someone who has latent TB, the risk of HIV progression is also increased. And that patient is given ART, there is a risk of TB iris. So this is all the function of immune dysregulation. So it's already been discussed that people living with HIV have higher risk of falling ill from TB infections than HIV negative people. Both HIV positive patients should be offered testing for TB, and TB patients should be offered testing for HIV. But this is not so much easy. Diagnosing HIV is kind of easy because the testing is easier. You get now the rapid test and the sensitive test are available, and the point of care testing is also available, so it's kind of easy. TB diagnosis TB, particularly extrapulmonary TB, biliary TB could be a difficult scenario, and particularly in the source limiting setting, it could be a time of, it could be a challenge diagnosing TB. So estimating the real burden, the real scenario, how much patients, HIV patients have active TB, how much TB patients have HIV, knowing how much TB patients have HIV is kind of easy, but how many TB HIV positive patients have actually TB or extrapulmonary TB or what kind of TB, it's kind of difficult because the diagnosing TB in HIV patients is kind of difficult and could be a diagnostic dilemma in some of the cases. So as discussed, the significant presentation of active TB could be altered in patients who have CD4 count less than 200, and the presentation could be atypical, as discussed in the previous presentation by Dr. Naseem, that they can present with disseminated TB, TB abscesses, biliary TB, extrapulmonary TB, abdominal TB, serositis, atypical clinical and radiological pictures, which broad differential diagnosis, and sometimes even the smear is negative. The culture could be negative, but you just treat them empirically because with anti-tuberculosis therapy, because not treating TB with HIV, not treating TB in HIV positive patients could be a disastrous thing, right? So sometimes patients present with weight loss, fever, hemoptysis very occasionally, cavitation is very rare, and cough may be present for less than 2 weeks. So it's not that cough present for 2 weeks should be a criteria for discriminating TB from other bacterial infections. These patients may present acutely with severe shortness of breath, which is not present for a long time, and cough could be a shorter duration, that is 10 to 15 days, that's it. And in this present scenario, when the COVID is there and we are seeing cases of long COVID syndrome, the diagnosis could be a real challenge. So in advanced HIV, the ratio of extrapulmonary disease could be 50-50. In early HIV disease, majority of the patients present with pulmonary disease. And clinical presentation, majority of the patients, they behave as a primary TB, as I told that, and as previously, because they can present with meningitis, biliary TB, TB adenitis, abdominal TB. Lymphadenopathy is kind of very common. The cavitation is rare. Tuberculin test could not give any information because of energy. It could be negative. Sputum smear positivity drops to 30 to 40%, and relapses and reactivation and activation of uh, activation of this latent TB is really common. So it's common, and also reinfections are also common in this population. So if living in endemic area, one of the presentation could be reinfection or reactivation. So patients who may have been treated with TB 10 years, 15 years back may acquire, if they have HIV, may be reinfected with TB. So that is also should also be kept in mind that reinfection can be present in this population. So someone who had been treated with TB in the past, this should not be a criteria of exclusion. That person again should be, if present with symptoms suggestive of TB, should be tested for TB. Extrapulmonary TB, we see lots of patients in our population with presenting with extrapulmonary TB, TB lymphadenitis, TB serotitis. So if someone is presenting with exudative fluid on and if you're suspecting TB serotitis like pericarditis, peritonitis, or pleural effusion, and when you drain the fluid and do DIA, and if it is exudative, and HIV positive patients think of having TB, and the gene expert and smear can be negative in those patients. Even the culture, we have seen patients that they have negative culture. We give them trial of ATT, but they actually kind of respond very well on antituberculous therapy and ARV. They may present with abdominal tuberculosis, abdominal obstruction, TB meningitis. If you are suspecting TB in an HIV positive patient, treat TB, because not treating TB could be disastrous. I told you that because diagnosis of TB with HIV co-infection is kind of difficult, HIV testing is easily, but diagnosis of extrapulmonary TB, biliary TB in a response lymphatic setting could be a challenge. There are many tests that have been tried. Always, if you have smear available, tissue fluid available, get AV smear, sputum smear microscopy could be advantageous that you can see the bacilli directly, but the yield could be low in case of biliary TB. Gene expert is a wonderful investigation. You can get information of preferences and resistance, but gene expert could remain positive for 5 years after TB treatment. So in the endemic area, studies need to be conducted to see the validity of TB and gene expert in diagnosis, validity of gene expert in diagnosis TB, because it could remain positive even if someone has received ATT and may not be suffering from TB. Radiography, urinary lamp has been used widely in African countries, and the sensitivity is really good if the CD4 count is less than 100. But this modality has been used widely in Pakistan. So Pakistan, we don't have urinary lamp or TB lab, which is a PCR-based method in which you visually see that whether the genetic material for TB is present in the sputum or not. And it could be very good point of care testing, but this is not available in Pakistan. So this shows that if someone is exposed to TB, in case of if not having HIV, the risk of progressive primary TB could be 10%, and the latent TB is 90%. But if someone is HIV infected, the risk of reinfection is also high, and there is 10% annual risk of having active TB, which could present as smear negative TB, extrapulmonary TB, multi-site disseminated disease, lower lobe involvement, intrathoracic lymphadenopathy, lymphadocervical lymphadenopathy, cavitation is rare. IGRA and tuberculosis test could not be diagnostic, could not help much because energy is there, and sputum smear frequently negative, so this diagnosis could be a challenge. Management of TB in HIV is the standard. So we use for drug sensitive TB, for the standard 4-drug combination is used. That is for 6 months, for 2 months we give HREZ, that is isoniazid, rifampicin, ethambutol, and pyrazinamide. And for 4 months, isoniazid and rifampicin is given except in CNS TB, where the treatment is prolonged, and it is for 9 to 12 months. For MDR TB, it's better to treat them according to the guidelines and refer them. It is better if someone is having MDR TB, the patient should be referred to the programs who are actively managing MDR TB, and the treatment is same as someone is given in non-HIV patients. It's similar, but the caution should be practiced with bedaquiline and ARV, because sometimes fatal arrhythmias can occur. Now, when to start ART? A difficult question. So, ART, risk of virus, deferred ART, risk of HIV disease progression. Don't know. The majority of the guidelines still recommend that if CD4 count is less than 50 cells, then ART should be started within 2 weeks of starting TB treatment. And if CD4 count is greater than 50 cells per cubic millimeter, one should defer from starting ART for at least 8 weeks, and 8 weeks gap should be given after starting TB treatment. WHO now recommends the new guidelines, which were recently made available, that is March 2021. Now recommends that irrespective of the CD4 count, start ARV within 2 weeks of TB treatment initiation, except in TB meningitis, where higher rate of adverse events are seen, and that have been reported if ARV is started before 8 weeks. So wait in TB meningitis, and evidence supports waiting for minimum 8 weeks because the paradoxical reaction or immune reconstitution syndrome in case of TB meningitis could be really effective. In case of pregnancy, regardless of CD4 count, start ARV immediately because we have to protect the fetus. And if ARV is deferred, the risk of transmission of HIV to the fetus is really higher. So in Pakistan, now that National AIDS Control Program is rolling out dolutegravir-based regimens, and preferably all patients who were doing well on TDF, that is tenofovir, lamivudine, efavirenz, were shifted to tenofovir, lamivudine, and dolutegravir. So WHO recommends 2 treatment regimens, first-line treatment regime, and 2 combinations, 6-dose combinations are available in Pakistan. That is tenofovir, CTC, that is lamivudine, efavirenz, and tenofovir, lamivudine, and dolutegravir. And in case of someone who has TB and who is getting rifampicin-based regimen, the dolutegravir should be given in a double dose and substituted as 1 dolutegravir tablet in AM or PM, along with the 6-dose combination, that is tenofovir, lamivudine, and dolutegravir. And this combination has been preferably used in Pakistan since the beginning of 2021. Individuals who develop TB on ARV and kind of stable, their viral load is suppressed and the resistance has been excluded, they should continue the same regimen. The immune reconstitution syndrome has been widely discussed by the professor, and I'm not going into detail. So the recommendation is to continue ART, continue manage antituberculous therapy, and use anti-inflammatory drugs or corticosteroids for 5 to 10 days could be continued for 60. So clinical trials have demonstrated that isoniazid therapy for space preventive therapy has been shown effective for prevention of conversion of latent tuberculosis to active infection in people with HIV. And it reduces the risk of active TB. So someone who had positive tuberculosis skin test and active TB or positive IGRA, that is interferon gamma release assay, after active TB has been excluded, should be given isoniazid preventive therapy. So in Pakistan, we usually prefer 6 to 9 months of isoniazid because the drug, the rifampicin, the resistance, the baseline resistance for rifampicin and drug-resistant TB is really high, and it is estimated that 10% of TB cases have resistance to rifampicin. So we avoid isoniazid rifampicin-based regimen for preventive therapy and usually give them ask patients to take 6 to 9 months of isoniazid, and it has been shown to be really effective and tolerated well by the public, by the people who have HIV and are taking ARVs. But the things are not really very rosy, very good. And this data shows, this is the global data, that the provision of isoniazid preventive therapy, except in Africa and rest of the world, is really, really low. It has not changed significantly from 2005 to 2019. And the uptick for us in Pakistan, even in Pakistan, the isoniazid preventive therapy has not been widely used, and patients are not prescribed isoniazid a lot who are on HIV. But as Dr. Naseem said, this is now being the government is trying to make it part of the program, and I hope that once it's part of the program, and with the session like the ones we are conducting, people would use isoniazid a lot as a preventive therapy in population who are living with HIV and or on ARV. The WHO has used it says that there are 6 I's which should be incorporated in the program to reduce TB burden in people living with HIV, and Pakistan is also part of is trying to integrate these services, and I think all these things part of the program to stop TB, to control TB, which includes intensified case finding for both HIV and ARV, as soon as preventive therapy, good infection control in healthcare settings and in communities, integration of TB and HIV programs, initiating antiretroviral therapy in people who need it, because ARV can also be, if ARV is initiated at appropriate time, the risk of acquiring TB and reactivation is low. And involvement of the communities in managing TB and HIV, and reducing the stigma associated with the disease, and encourage them to seek care. So thank you so much. So if there are any questions, you're more than welcome to ask. And over to our host.
Thank you, Dr. Lakshmi, for a nice presentation. So before we start the questions, I just want to tell the audience that next week they will receive the evaluation forms, whoever attending all those 5 webinars to complete evaluations, and then they will receive a certificate of participation. With this, I will ask all the panelists to please turn on their camera so we can start through the questions and answer sessions. We have multiple questions here. The first questions, few of questions have been answered in the chat box, but I can start with the first question is combination therapy of TB in children, TB and HIV. So Dr. Kwara, you want to answer that question? Is there any combination therapy for TB and HIV in children?
Yes, for the TB drugs. So the TB drugs has fixed dose combinations, but for the ART, they don't currently have a combination that has all three drugs. You may have a fixed dose combination of lamivudine and AZT, which is called Compivir or Diovir, and they have a pediatric formulation of that. But then you have to combine it with the efavirenz. The only time you can use the fixed dose dolutegravir is if a child is weighing more than 20 kilos, they can use the fixed dose dolutegravir, tenofovir, lamivudine just as adults. But anything else, you may have to do a combination of the ART.
Okay, excellent, excellent, good. Thank you. Next question is for Dr. Naseem Akhtar. Is this, if the TB bacilli detects through the PCR, then why the TB culture is necessary? Dr. Akhtar, please. You are muted. Dr. Akhtar, you're muted.
Okay, so the question.
You're muted again.
I think you can hear me now.
Yeah.
Yeah. The TB culture is important because, on expert testing and on smear, you just come to know that tuberculosis is there. But on expert testing, you are able to know that rifampicin resistance is there or not. There are more tests available to know more about the details of the sensitivity about the anti-TB therapy. Like, we can have line probe assay, which can tell us about the sensitivity pattern of other drugs. And it also is a first generation line probe assay and then second generation. And we can also test for, injectables and quinolones on it. And TB culture is necessary because, sometimes it's not necessary that you have resistance to only one or two drugs. Sometimes you have resistance to 3 drugs. Sometimes there is resistance to 1 drug. So more detailed evaluation of a patient is possible once you do a culture. And sometimes you also do not come across positive reports on smear or as well as on expert testing. And then you treat the patient on the basis of your clinical suspicion, and then you wait for the report to come, and then you modify your therapy on the basis of the culture report.
Excellent. Yeah, thank you. Next question is for Dr. Lakshmi. If the patient has pneumonia and TB, which one would you treat first?
So pneumonia and TB, I mean, it depends on the presentation in a clinical setting. So if someone presents with coolant sputum, fever, chills, has a recent onset patch on chest X-ray, you would of course give trial of antibiotics. But if patient does not respond to antibiotics in 10 days time, in 7 to 10 days, if you get therapy for 7 to 10 days, then you would think of TB and you would evaluate for tuberculosis in our setting.
Okay, sure. Thank you. Next question is for Dr. Kwara. I think based on your experience in Ghana, also, I think you can tell us, Pakistan has one of the highest TB burden in the world, again, pretty close to just like in Africa. So HIV is not reported due to, detection and monitoring, and, so how do you think any strategy Pakistan can implement to prevent that spread of the HIV, or something has been successful in Africa? Because I slightly modified the question because I think it applies to both in Pakistan.
Yeah. So the question is about spread of HIV. Is that right?
Correct. What strategies Pakistan can apply to prevent that? Yeah.
Yes. So you now know that with HIV treatment, if somebody has HIV, they are treated with antiretroviral therapy and they are undetectable. They can no longer transmit HIV. So it's called treatment as prevention. So it's one of the options that we have. So in communities where HIV incidence is higher than the general population, as much as possible, early testing, least suspicion, you test for HIV, you detect the HIV, you treat with antiretroviral. Once they become undetectable, then their chances of transmitting to anybody else is almost zero. Then there are other preventive options. I don't know if they do PrEP in Pakistan, but you have a couple. One is HIV infected, the partner is not. They have what you do, 2 of the HIV medicines for the HIV negative person to take to prevent them from acquiring HIV from their partner. But again, treatment as prevention of the index person will have the highest impact. And then again, use of condoms and so on is all important. But early testing, early treatment to virologic suppression is really, really key. And not Pakistan alone, the whole world is being used as an option to prevent TB transmission, HIV transmission.
Yeah, no, absolutely, you're right. Early detection, early treatment, so that's the most important message I think people can take. The other question I think was answered, but the question has been if the patient has both infection, HIV and the TB at the time of diagnosis, which we treat first, and I think which was answered by multiple all of you guys, that they according to new WHO guidelines and whatever understanding is, you should treat them both as soon as possible. So that's a bottom line answer. And then there's another question which I think Dr. Akhtar can answer. Who are treating the co-infection in Pakistan? Like who's the physician, like the IDA, the primary care, how they are diagnosed, and how special center, multiple centers were mentioned, how they treat the TB HIV in Pakistan. The co-infection, who's managing them, who's in charge? Dr. Akhtar, you are muted again.
Sorry.
No.
So in Pakistan, we have established HIV treatment centers, as well as we also have DOTS TB facilities. So there are certain sentinel sites where both facilities are available in, under one roof. So basically, we have appointed medical officers who are trained for diagnosis and for both for tuberculosis as well as for HIV. So in both the centers, they know that how to diagnose, which specimen is to be sent, and then to establish linkage between those cases who are both positive for TB as well as HIV. So so basically these trained staff is there, but at the same time we also have collaboration with infectious disease departments in the hospitals where this facility is available, because ID is not that much established as a department all across the country. So wherever the facility is available, we link these treating physicians with the ID specialist, and they most often come to us and they seek advice. And at the same time, we also keep on, giving them refresher trainings, both on the diagnosis of TB as well as HIV.
Yeah, thank you. Thank you.
Just one more thing about the prevention. I forgot to talk about pregnant women and children. The way children get HIV is through their mother. So testing of all pregnant women for HIV is really, really a key intervention. And if a pregnant woman is HIV infected, they should be started on ART as soon as possible to prevent them from transmitting to their child. And so that's another preventive thing that people should be aware of.
Correct. I think there was a case at UMass at our institution where one of the physicians, they completely prevented by treating the mother, but completely prevented the transmission to the unborn child. That was a few years ago. So yes, it can be needs to be treated, diagnosed aggressively. The mother is treated so the child wouldn't get the infection. Next question is about the pharmacovigilance of TB drugs in Pakistan. The question is from Mr. Abdul Rashid that nowadays there's a weak system of TB monitoring. There's no ADR of TB drugs collected in Sindh and Balochistan. So what was the pharmacovigilance of TB drugs? I think Dr. Lakshmi probably can answer that question.
Yeah. Actually, the system of pharmacovigilance is not really that much developed in our part of the world. So because these patients, they go into the communities, they get their medicines from the TB centers and from the HIV centers, but they follow for their adverse reactions with their GPs. So data is really an issue, and monitoring them for ADR is kind of difficult. So once they come to the centers where they have been prescribed these medications, the medications are stopped, but of course, reporting of ADR in a formal way and data collection is really, really a problem and is not really widely available in our part of the world. but the systems are actually developing. The country is developing, and when so many people are into the loop and they're doing so well, probably in a very small time, pharmacovigilance and reporting of areas would also be taken care of by the government officials, and it would be part of policy. But right now, there's no such system in place.
Sure. Yeah. Yeah, unfortunately. I think there's the next question also on the same lines. There's a lot of medication errors, more than 12.5%, and in the public, and the 6.6% error in the private sector. And then I think the answer lies in the same data collection, and then how to prevent those errors. Institutions needs to take steps to prevent those errors. So along the same lines, next question is. How's TB is tested in HIV people other than extra chest and early? You can miss an early TB. So I believe the answer lies in sputum cultures, sputum AFB. Dr. Lakshmi, you probably deal with those every day.
Yeah, so I told you that diagnosis is not really very easy now because sputum sensitivity is really low in patients with advanced HIV. Then gene expert has only been tested for sputum, and gene expert can remain positive for a long time. If someone has received TB previously, it may remain positive for 5 years. Then the sensitivity for gene expert is low in fluids, and these patients usually present with extrapulmonary TB, histopathology, maybe you see a granuloma with cases necrosis. So it's a kind of challenge diagnosing TB and HIV in advanced HIV because the presentation is atypical. Urine lamp is good investigation with high sensitivity and specificity in people living with HIV in Pakistan, but in people who have CD4 count less than 100, but it is not available in Pakistan. So not all of the investigations are available. So that test, that we don't have that. That has been tried in Africa and with really good sensitivity and specificity. It's a good test. So it's kind of challenge. So if we are suspecting TB in a patient with advanced HIV, it's better to treat than not to treat, because if you're not treating, the disease may progress rapidly and the patient may lose his life because of TB. And TB, dying of TB in nowadays is kind of sad when you have got so many effective drugs and treatment options available. Even you have got good treatment options for drug-resistant TB. So if someone is dying of TB now, when you have got good therapeutic modalities available, is sad. So if suspicion is high, I would suggest that rather treat them for 6 months with APT than not to treat. With TB,
right. No,
because the drug interactions are minimal. Most of the people, majority of the people tolerate TB drugs, anti-TB drugs really well. So if you have excluded all the possible causes, I mean, as a clinician, I would treat with anti-tuberculosis drugs for 6 months rather than not to treat.
Yeah, no, you're absolutely right. When that we have both diseases, HIV, TB, are treatable, controllable, and not treating that would be a big tragedy for anybody to die from those diseases now. Next question, I think Dr. Kwara can. I think you did slightly touch upon it. That in the TB endemic countries like Pakistan or Ghana or any African country, how long do you prescribe the isoniazid prophylaxis in the people living with HIV, PL-HIV patients? How long the prophylaxis should be?
Yeah, so currently the WHO guidelines say 6 to 9 months.
6 to 9 months, okay.
So that's something that most countries haven't really adopted, including Ghana, but they are now starting to do it. You screen all HIV people with symptoms just to be sure that they don't have active TB. And if they don't have active TB, you can do the preventive therapy 6 to 9 months of isoniazid. In future, isoniazid rifampicin will become available, but that is not widely available yet. And that's a shorter course.
Can you repeat it again? There's another question on the same lines. Can you repeat the INH therapy if you've done one time and then you did 6 to 9 months ago? Can you repeat it again?
Yeah, so 6 to 9 months for isoniazid preventive therapy is called IPT. Now, they've done studies where 3 months of once weekly isoniazid rifampicin can also prevent TB in HIV co-infected, but that regimen is not widely available yet. But I'm sure in future, it will also become an option. So when it becomes an option, you could actually do 3 months of isoniazid rifampicin. Rifampicin for 4 months is an option in some countries, as it was already pointed out, but it's not, each country decides whether they want to jeopardize their rifampicin alone or not, and may not use it for preventive therapy. They will use it only for treatment. So isoniazid for 6 to 9 months. In the near future, you have isoniazid rifampicin.
Thank you. Thank you very much. I think the next question is Dr. Akhtar can answer, because I think she works in the healthcare department. So what are the guidelines for HIV screening in Pakistan nowadays? I think you did mention about screening all the patients with the TB and all the patients suspected, but are there any specific guidelines that people need to follow?
The guidelines for both TB and HIV are available on the website of National AIDS Control Program and the National TB Control Program. And as far as the testing for HIV in TB and for TB in HIV, these are the guidelines incorporated in our TB guidelines as well. And we are now advocating that these guidelines should be followed all across the country in all the provinces uniformly. Since you know that we already have disseminated this message, but still we are not providing testing in both the areas. We need more work on awareness and dissemination of this message all across the country on various forums, especially among the pulmonologists and those people who are treating TB patients, and at the same time those who are treating HIV patients.
Okay. Next question is also for you, Dr. Akhtar. You did mention that directly observed treatment. Again, we all know that's well-known treatment for many decades now. So Dr. Hussain is asking, how hard in Pakistan for keeping patients comply with the treatment, combination treatment. So treatment with one disease is trouble, but treating with the two conditions, is there any directly observed treatment for TB and co-infection in Pakistan right now? Is there any centers of protocols?
Thank you very much. Treating tuberculosis in HIV and treating HIV itself is a big challenge in Pakistan. And here the main issue is that most of the patients, they come to the HIV centers when they have an advanced HIV disease. The reason being that they face a lot of stigma and discrimination, and there is a fear that their relatives will come to know that they are suffering from HIV. Majority of the patients who are tested positive, they are basically deported from different countries where they go for their jobs and business. And once they come to Pakistan, most of the time they are in a very good health status, and they hide this disease from the rest of the family as well as from the healthcare providers. And once they come to have some advanced features like weight loss and fungal infections and TB meningitis and all that, different opportunistic infections, then they seek advice from the doctors, and at the same time they continue to hide the diagnosis. And this is the main dilemma. And since TB is very, very common among these patients, obviously, most of the time, we first think of tuberculosis rather than thinking of many other opportunistic infections which are rare in this part of the world. So, we advise our physicians to assess the history of the patients, whether they have history of some foreign travel or whether they have some kind of risky behavior. And, there's a list of these risky behaviors which we advise that our physicians should be, whenever a patient comes with some kind of opportunistic infection, they should look for that. And then they should get HIV rapid testing. And these tests are available free of cost in most of the centers at the Sentinel sites. And if they do not have that Sentinel site at their area, they can refer these patients to a place where screening facility is available. And we have the rapid diagnostic tests which are WHO approved, and they are available in the sites. And we have provided with the guidelines that they should again confirm the case if there is a suspicion. And then if the patient have, I think the main question was the compliance to the treatment. So once the patient is in the advanced disease, we try to, stabilize the patient first. And if the TB infection is there, we start with anti-TB drugs, and we see that if patient is able to tolerate well and starts eating and drinking, and we start antiretroviral therapy as soon as possible. So counseling is very, very important, and not only the counseling of the patient, but also the counseling of the attendants and the family members, because family members are the main supporters or social support providers in our setup. So the main issue which we face in our country is the IV drug abusers, because they are not only tested positive for HIV, they also have TB, and it becomes very, very difficult, to ask them to continue with the treatment, because we have to work more on the rehabilitation centers, and we have to stabilize these patients, because they again indulge in IV drug abuse, and they become they lost to follow up, and they die ultimately. So this is a big challenge, and it needs a lot of awareness and dissemination of knowledge, and keeping an eye on such kind of patients so that they are compliant to the treatment.
Sure, excellent. It's 12:41 now, so I thought we can ask, have few more questions, and we can end the talk unless the panelists are available, and we can continue to finish all the questions we have. So I will read the next question and then quickly answer it. There is a question from Mr. Abdul Rashid that antimicrobial resistance of TB and HIV medication can be reduced. What are the steps taken to minimize the resistance? There is no data. So this is a problem in any developing country. There's no data. So it's something which can be asked from the government officials. The data collection is part of the government's job to do. So definitely, we completely agree. The data needs to be collected, and resistance needs to be documented, and people should be treated appropriately. Next question is about that from Ms. Saima Abbas, that what are the recommendations for latent TB, in a newly diagnosed AIDS patient? Can you postpone treatment of latent TB? Dr. Kwara, I think you might be able to answer that.
No, so latent TB, if you are diagnosed with HIV, you've done the symptom questionnaire, they don't have active TB. That means they have no fever, no cough, no weight loss, no night sweats, and you've ruled out active TB. Some people may even do an X-ray just to be sure that it's clear. If that is negative and you've started ART, you can start isoniazid at any point. You don't really have to wait too long. The IPT or isoniazid therapy is being done by programs, and typically national programs will have guidelines for it. But once you start HIV treatment, you've ruled out active TB, you can start isoniazid therapy and do 6 to 9 months.
Excellent. Yeah, thank you. Next question is a very important question, also from Dr. Syed Hussain. That is it true people in Pakistan get the BCG vaccination, so they are positive for the TB skin? Dr. Akhtar can answer that. So people, in my personal experience, I'm BCG. I got the vaccine, but I'm skin test negative. So I believe 50% of people are negative even after getting the BCG vaccine. But Dr. Akhtar, also, so how do you, again, it's become some diagnostic challenge for some people. Your TB, you got the vaccine, now your TB skin positive, and what do you do? So please share your experience with that.
Yeah, thank you very much. In immunocompromised patient, we do not have much of the significance of this, test like Monto's test or, IGRA test. Although IGRA test is better, that it is not affected by the BCG vaccination status. And I would like to mention over here that there was some question by Dr. Saima as well in the chat box. IGRA testing or the quantiferon gold tests in Pakistan are available, and they are helpful to some extent. But I see that they are so much expensive and they are not readily available everywhere. And secondly, we cannot differentiate between active and latent tuberculosis on the basis of these tests in Pakistan, especially where the TB is very, very endemic. So most of the time we do not offer such kind of testing because patients are non-affording and these tests are not freely available or free of cost available in the government setups. So Monto's test is badly affected by the immune status of the patient, and especially in case of advanced HIV disease, they usually turn negative. And on the basis of this positive or negative Montus test, we do not decide about the treatment, in cases of HIV. Most of the time we go for the clinical scenario. If there is a strong suspicion of tuberculosis, whether pulmonary or extrapulmonary or CNS TB, we get chest X-ray done, we get sputum studies done if there is something in the chest X-ray, or we get the CSF analysis, and we go for the other tests other than IGRA or Montus test. Although sometimes they can be of help, but in HIV cases, I do not find them of much value, especially in our country where TB is so much common.
Okay. So next question is actually about addiction. So I'm not sure anybody trend here is to tell us about the addiction. Dr. Saeed Hussain is asking about the psychiatric diagnosis addiction. Is there any protocol to bring addicted patient to centers offer mental health? If somebody knows, I know this is not an addiction panel on addiction, but if somebody has knowledge about some problem in some protocols in Pakistan, pretty more than open for anybody to answer it.
I think I may answer this question partially, and Dr. Bushra Jamil is also over here in our group, and she can also second my answer. In Pakistan, we have some rehabilitation centers which are run by the private NGOs, and they usually provide counseling. At the same time, they also offer testing for HIV, and they do test for TB as well, and they refer such kind of patients to our HIV center once they are tested positive for TB. And they provide psychological counseling for the treatment adherence, and for testing and rehabilitation, they work on that. So if Dr. Bushra has something to add, so she is here.
Dr. Bushra, you want to add on to that question? The centers? Yeah.
Sorry, my connection is unstable. Can you please repeat the question?
So the question is about the addiction treatment centers in Pakistan. How people there are centers where they can get mental health treatment, again not directly related to HIV, but again all those people have unfortunately HIV also, or some people have tuberculosis or chronic illnesses, and they have mental health issues too on the top of that. So how they get a comprehensive treatment?
There are treatment centers for addiction, but those treatment centers are mainly run by private groups, so they are not government-run treatment centers. And I have not come across any center which offers comprehensive treatment for any infection, neither TB nor HIV. So this is one thing which we need to look at and actually build linkages. So these are being run independently of TB and HIV programs. So this is one problem.
Oh, okay, good. Thank you very much. So
Yusuf, I have one very small question. This question keeps coming back in every webinar, and people want to know the patients with HIV or HIV Hep C or HIV TB. What are the recommendations for COVID vaccine? I don't know, but this question is in every webinar. So if anyone can answer about to this question.
So if someone is having stable HIV, doing well on ARV, viral load suppressed, he is like a normal person.
Right.
So should get vaccinated for COVID. I mean, there's no contraindication for COVID vaccine and HIV positive patients as like any immunization. So someone who is doing well, who is stable, who is not having any can get HIV. Someone who has been on ARV, have started ARV recently, CD4 normal, even if it's not virally suppressed, or even CD4 is not normal, but someone who is stable on ARV or not on ARV, HIV positive, should get COVID vaccination irrespective of his HIV status. So vaccine, everyone should get vaccinated. I mean, there is no absolute contraindication for vaccine now.
Okay. So Dr. Kwara, what is your answer?
It is like someone pregnant, lactation, transplant, stable persons, active TB, non-active TB.
Okay,
everyone should get COVID vaccination. I mean, that's the message through this forum.
Yeah, thanks for this answer. So Dr. Kwara, what is your experience in USA.
Yeah, so we are really advising all our patients
Yes.
to get the COVID vaccine. No contraindication at all. They haven't been studied as a single group, but we know that the vaccine works in a lot of populations. So we recommend, and when they come to clinic, we just check, did you get a COVID vaccine? If not, none that is generally available everywhere. We just tell them to go get it.
Okay, good. Thank you very much.
Very good. So it's 12:50 now, so I think we can end our webinar. We had more than 100 people participating webinar today, and an outstanding response. And I'm happy that people from Pakistan's frontline people who directly treat people with HIV and AIDS and tuberculosis, and that's the hospital that I worked in Pakistan, so were present today. So I believe it will be an informative, it must have been an informative session for everyone. So please feel free to ask, send us email at APPNA-MERIT, the email that you must have received from when you register for the webinar. If you have more questions, we can forward it to your questions to the panelists. So thank you very much.
Yes. Special thank you to Dr. Yusuf Sheikh and all of our presenters and panelists. Thank you very much.
Thank you.
Okay, thank you, and bye everybody.
Thank you very much.
Good night.
Yeah.
Night.
Sure.
Thank you.